When is the best time to start?
Good question. I mean, the minute you have symptoms, when we look at mental health, for sure, the earlier the better. The earlier you can stabilize what's going on in the brain, the much better you're going to be for both cognition and mental health. And most likely, especially you have the ApoE4 gene for dementia risk for a woman. If women on hormone therapy with that gene specifically have higher brain volumes and better cognitive scores as they age than women who were not given the opportunity to have that medication. For bones, the earlier the better. For heart disease, we have a window of opportunity. So the estrogen is really protective of the endothelium and the development of plaques and further calcification of plaques and then narrowing and et cetera. And so estrogen just helps keep the elasticity in the endothelium, and it decreases the rate of plaque formation. She will probably still develop plaques, but it's going to be later. But once those plaques form, it's not helpful. So estrogen, as far as cardiovascular disease prevention, is better at prevention than cure.
That makes sense.
So telling a woman in her 60s that estrogen could protect her heart is a misnomer.
Got it. So it's better, earlier on. As opposed to later. But is it ever too late?
So it depends on what we're trying to treat. It will always help her bones for her whole life. It will always protect her vagina, and we can do topical vaginal estrogen for that. We're probably going to lose cardiovascular benefit over time, and each woman is different when that happens. But there are cases, and myself included, where I might die with an estradiol patch on, happy as a clam. And as long as I don't develop an absolute contraindication where my life would be in danger from this medication, I will probably continue to use it, because at 56, and I don't know how old your demographics are, but I am absolutely living my best life. I wake up happy every day. I am sleeping better. I have better relationships. I have better nutrition. I work out to make myself stronger. I understand my path and where I'm going, and I'm super happy about it. And women are not being allowed to feel that way. They're going and complaining to their clinicians, I don't feel good, I'm gaining weight, I'm not sleeping, and a lot of them are getting patted on the knee and saying, well, this is just what women go through.
Wow.
At this age.
Yeah, I mean, I see that constantly from my audience is pretty split, but I do have a large, significant female following, and and this is very it's consistent with what I hear. Is a patch, is that a typical administration?
So when we look at human hormones, you have estrogen, I have estrogen, you have testosterone. We all three you have a little bit of everything. You have a lot of testosterone. So we look at how do we replace all three, and would you replace all three? So we usually start with estrogen, and for systemic therapy, meaning I'm going into the bloodstream and we're treating brains, bones, everything, right? You have oral. So two big classes are oral and non-oral. So oral, we ingest, it goes through the stomach, picked up by the liver. When we go to the liver for processing first, that first pass effect of the liver for estrogen, we see a slight uptick in her clotting factors. So for women at risk for clots who've had a history or have a known clotting disorder, we are going to avoid that formulation for her. Oral estradiol is really cheap. And so for a patient on a budget, it could be a really good option. We have lots of strengths. It's easier to kind of titrate. But we do kind of have that, dose-dependent increased risk of clotting for a certain percent. It's very small, but it is there. Then we have non-oral. So, we have patches, pills, creams, gels, rings. Multiple ways to get it into the body, avoiding the gastrointestinal tract. For price, my patients are on a budget. I usually stick with a patch because we have multiple strengths. So I have a lot of wiggle room, because in perimenopause, it is literally pinning the tail on a moving donkey, and we have to chase her around to get her stable. And then in postmenopause, it's a little bit easier because she's bottomed out. So we're just giving her back, And so the patch has multiple strengths, and it's very, very affordable. For progesterone, the safest formulation does appear to be the body identical progesterone, and oral is best. Doesn't really affect the liver, and we have really good absorption. Progesterone is a huge molecule. It does not absorb well through the skin in its natural form. So we do have progestins through the skin, like what's in a combi patch or some of the commercial preparations, but they're synthetic, and the best safety data does really seem to be in the natural progesterone.
Is testosterone being replaced?
Yes. It's FDA approved for men, as we all know, but there's no FDA approved for women, so you're going to pay out of pocket for it. We want to avoid oral formulations. There's one available in Australia called undecanoate that doesn't affect the liver. It kind of skips the liver, but we don't have it in the U.S. So most of us do injectables or transdermal for testosterone preps. And There's an androgel. So it's a testosterone gel that absorbs really well through the skin, and we monitor their levels. You have to make sure she's absorbing and how much. We don't want to overshoot, but patients are really happy with it. And the nice thing is, because it's formulated for men, that one bottle will last her about 6 months because we don't need very much.
Right.
And with a good RX coupon, we can probably get a bottle for about $60. So I can get my patients' hormones replaced for less than $100 a month with high quality FDA approved body identical hormones.
Wow. Yeah. I mean, women, I feel like...
I know women are paying thousands of dollars. That's why I say that. You don't have to pay that much to get great hormones.
Is it covered? Does HRT tend to be covered by insurance? I have no idea. Yes.
In the forms of estrogen and progestogens, yes.
Just for like wellness?
But sometimes, the way these pharmacy benefits work, sometimes paying out of pocket is cheaper than paying the insurance price. So I'm always like, shop around, ask, see what the prices are, and I can move the prescription from one pharmacy to the other so you can get the best benefit.
Can your lifestyle in your 30s predict how bad your menopause symptoms will be?
So we have things that happen to everyone: loss of muscle, loss of bone, genital urinary syndrome of menopause, that are going to happen, right? And then we have things like hot flashes, night sweats, that, yes, lifestyle can absolutely attenuate that. So kind of how healthy you show up in menopause will sometimes determine your course of, are you going to have really bad hot flashes? So women who are obese tend to have worse hot flashes. Women who have poor nutritional status tend to have worse hot flashes. But I don't want to make anyone feel bad. I have the healthiest people on the planet come to see me who have debilitating symptoms despite perfection in their diet, nutrition, and supplements. And they're still just absolutely, so it's not an all or nothing. It's a trend. But, no one should feel bad because they have bad symptoms.
When it comes to body fat, is there like a specific range?
So, women have more body fat than men naturally, and it's healthy. But when we start moving into, so we've redefined obesity away from just the BMI. So when we're looking at waist hip circumference, so when their abdominal circumference, or I use the waist hip circumference in my clinic, well, we mostly use visceral fat because I really don't care about their curves, When their visceral fat gets above the 100th percentile, we're more likely to be more symptomatic. And there was a great study that I just posted about it yesterday, that looked at visceral fat. The higher your visceral fat, the more likely you are to have osteoporosis.
Wow. And this is basically like the apple-shaped body versus the pear-shaped body,
right? So visceral fat, or belly fat for your listeners, is a very specific type of fat that is intra-abdominal, wrapping around our internal organs. So as a surgeon, it's when I stick a scope in the abdomen and you just see bright yellow everywhere around the omentum. It's wrapping around the bowel, fatty liver. We see it around the stomach, organs. And it's, a real sign that there's some really tough cardiometabolic activity going on.
Yeah, we've talked about quite a bit about visceral fat and how dangerous it can be. On the podcast, we had Dr. Sean Amara, who's he's a physician who focuses on that a lot. But doesn't the hormonal shift that occurs with menopause, doesn't that kind of predispose fat storage in the abdomen, or is that a myth?
When we lose the estrogen, we lose the protection against a lot of forms of inflammation. So you kind of enjoy this like honeymoon period. That's why premenopausal women are healthier than their male counterparts. Probably because we have higher estrogen. And then we pass you guys up and head, off the beaten path. And so we feel like estrogen is really protective. So the loss of estrogen is leading to increased insulin resistance, increasing LDL levels, the ApoB goes up, all with no changes in diet and exercise. So all of that, and then the inflammatory, we see C-reactive protein and SEB rates go up just from being menopausal. So a woman who's in premenopause has a rough, about 8% of her total body fat is visceral or intra-abdominal. And then she crosses over into full menopause and it's up to 23%. So to give you an idea.
Yeah.
So what do we know attenuates that? HRT absolutely attenuates that. Not 100%, but they do see much less accumulation, but high fiber diets, probiotics, a healthier gut, regular movement, zone 2 training, all of that does tend to decrease the amount of visceral fat. Sure, if we starved, that if you lose fat everywhere, you'll lose it there too, but that's not why we're here, right? You have to eat to be healthy.
Hey, if you like that video, you need to check out this one here, and I'll see you there.